Good afternoon, everyone. I'm here to present our group project in Applied Bayesian Statistics course that is modeling the risk of death in intensive care unit using Bayesian statistics. The reason for us to model the ICU mortality rate is that the ICU is an important area of study, as globally the disease burden requiring intensive care is growing. This is due to increase in accidentals, aging population, and etc. It is therefore important to model the in-ICU mortality rates. Further, a better understanding of what causes mortality will help to reduce the mortality rates, ultimately saving lives. The dataset is generated from Malaysian hospital, capturing data from 1,286 patients across 18 months. Data is filtered to exclude children and short-stay patients, and a total of 1,111 patient data were used for modeling. The modeling techniques we have used for the project are Bayesian logistics modeling, MCMC diagnostics modeling using JAX. As for the tool for this project, we used R, RStudio, and JAX. Next, we're going to move on to dataset description. As for the dataset description, we present visualizations with each feature in the dataset. Outcome is our target feature, and it is a dichotomous variable. We can see that the in-ICU mortality rate is around 90%, which is significantly high. We want to build a model that accurately helps us predict this outcome. The rest of the features that we want to use is also visualized. Some of the prominent ones include age, whose interquarter range is within 25 to 65. This is also an important consideration since we are not just dealing with people over 50 years old. We also observed that ethnicity is mostly Malay and some Chinese and Indians, and this is a fair representation of Malaysian population, and also an almost even occurrence of both genders. As we can see from the admission diagnosis plot, most of the patients who admitted to the hospital were diagnosed as having trauma or cardiovascular, and the others are not much at all. Chronic health groups plot indicates that almost 80% of patients did not have any chronic health issues. To study what affects mortality rate, we take a look at the relationship between our target variable, outcome, and the various predictors. It is clear from the box plot that APS, which means acute physiology score, is positively related to our mortality rate. We know that the APS score is an indication of patients' health factors, including heart rate, temperature, and etc. The worse they get, the worse the chances of survival. Patients who were diagnosed as having hematologic and trauma are less likely to survive. As for ICU admission source, if patients stay under the special care unit during treatment, they are more likely to survive. After dataset description and univariate analysis, now we move on to Bayesian model building. We went through 3 stages before developing our Bayesian logistics regression model. Firstly, we transformed the 6 categorical variables: gender, ethnicity, chronic health group, admission diagnostics, operation statistics, ventilation from the dataset, using dummy variables, converting them to multiple binary features. Secondly, we conducted collinearity analysis using correlation table of the dataset. We excluded several features as they have exhibited strong correlation to other features. Lastly, we conducted feature selection and ended up having 26 features as predictors and 1 target feature outcome. These features are included in the model for final model tuning. As our target variable is a dichotomous feature, we used Bayesian logistics regression model. We ran the model in JAX. We set up 6 chains, 20 thinning steps, 25,000 iterations, and 5,000 for burn-in. One of the parameters that we used is the guess coefficient that we added to see if adding a guess probability to the model increases the chance of accurate prediction. This is an important indicator of randomness in the data and possibility, which possibly indicates that there are other features that we could have used. For our modeling, we have used Bernoulli distribution for our model, as our dependent variable is dichotomous. We did not know the right prior values, and after some experimentation, we used a non-informative prior. Ideally, we want to get an expert opinion before we model them. For our continuous variables, we used parameters with standardized normal distribution with mean of 0 and variance of 10. As for the rest of independent variables, we used parameters with normal distribution with mean of 0 and variance of 10. The guessing parameter is with beta distribution, with alpha and beta values as 1 and 9. All of the information I have mentioned regarding the model is illustrated in the model diagram. The model string is a JAX code that is generated in R and stored in a file for JAX to process. Once the MCMC chains are running, we look at the model diagnostics. We start by analyzing the standardized variables first to see if they translate better once converted. As we can see from the plots, all chains are well mixed, shrink factor after burying are all below 1.1. There is no evidence of autocorrelation and all MCC are very low and is 0.01. This indicates that the Bayesian parameters that we get are all within thresholds and are very good estimates. Next, we look at a few of our transformed variables, and as above, they also show very good diagnostics. We notice that the guess coefficient that we added is very insignificant, which tells us that the data has all parameters that are needed for classification. The last stage that we want to do is to validate the coefficients that we obtained to look at significance. We see from the table that all the coefficients are significant, except for the guess-related ones. Thus, we can conclude that they all fit different pieces of puzzle. We then want to take a look at some samples of posterior distributions. And these all reflect that the model and parameters fit very well. All the features available in the dataset are significant in the prediction of outcome. It was also observed that there is no need of a guess parameter, and all the independent variables sufficiently explain the outcome. This is crucial in critical applications since we do not want to leave it to chance. As for limitations, priors used are non-informative. Hierarchical models can be built to better understand outcome by the various categorical variables. In terms of next steps, we can experiment with changing chains variance, thinning steps, and also with iterations. We should use of more complex models such as hierarchical models to identify in ICU mortality rates by ethnicity or by gender. We can also consider a set of candidate models to deal with model uncertainty. If you have any questions, please reach out to us on the below emails. Thank you for your patience.